Hi there, everyone, and welcome. We'll get started now that people have been able to get into the webinar. My name is Jeremy, and I'm a representative of EHN Canada. We are a nationwide network of treatment centers for addiction, trauma, and mental health. We have facilities located in Nanaimo, British Columbia, Calgary, Alberta, Toronto and Peterborough, Ontario, Montreal, Quebec, and Annapolis County, Nova Scotia. We offer high-quality inpatient, outpatient, and online treatment programs. For more information, please visit our website at ehncanada.com. Just for a little bit of housekeeping, everyone is on mute and cameras are off for today's webinar. But feel free to use the Q&A box located at the bottom of your screen to submit questions for our speaker. We will try to get to as many questions as possible at the end of the session. Today's webinar is in fact being recorded, and we will be sending out a follow-up email next week that will include the link to the video, the slides being presented, and any other useful resources, as well as your CEU certificate. I am currently in Toronto. Toronto is located on the traditional territory of several nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. It is covered by Treaty 13 with the Mississauga of the Credit. We also have presence today in Calgary, Alberta, the traditional territories of the Blackfoot Confederacy, which includes the Siksika, the Kainai, and the Piikani nations. This land is also traditional territory of the Tsuut'ina and the Waivinaik-Waiter nations, and the Métis Nation Region 3, and all people who make their homes in the Treaty 7 region of Southern Alberta. For today's topic, treatment options of major depressive disorder. We have Dr. Tim Ayaz, who is a psychiatrist at our EHN Sandstone facility located in Calgary. Dr. Ayaz completed his master's degree in public health, specializing in hospital administration at the University of Alberta, and worked briefly in hospital administration at the Massachusetts General Hospital and the Misericordia Hospital. He attended medical school at the University of Calgary and completed his residency in rural family medicine at the University of Alberta Red Deer site in 2005. After practicing for 2 years doing rural family medicine locums, urgent care, psychiatric extender shifts at FMC and PLC, and locums at Centennial Center Ponoka, Dr. Ayaz decided to complete a second residency in psychiatry at the University of Calgary and was chief resident in 2010. He went on to finish his psychiatric fellowship in 2011. Please welcome Dr. Ayaz.
Hi, everybody. Can you hear me? Jeremy, it says I can't start my video because the host has stopped it. Could you let me open it, please?
Yeah, of course.
Thank you. Perfect. Thank you, everybody. And thank you for attending today. And thank you for that introduction, Jeremy. Well appreciated. I was asked to go over treatment options for major depressive disorder, which is a very complex disorder to go over. And I'm going to try to finish my talk, though, to give you guys still at least about 15 minutes at the end for questions, which you can enter in the Q&A box. I do work here in the Calgary area, primarily working within the public system. However, I've recently joined the Edgewood Sandstone team as their inpatient addiction psychiatrist, and it's a great team to work with in a very intimate setting. So very happy to be there, as well as I do quite a lot of roles in the public system. I'm a clinical associate professor locally here. I'm actually in charge of addictions for the Calgary zone, as well as a number of other admin roles in terms of the medical school director and things like that. So, but I do a fair bit of clinical, both inpatient and outpatient for addictions and mental health. Concurrent disorders is generally my subspecialty, where I work with people with both a mental health disorder as well as an addiction. And obviously that comes in handy working in a concurrent disorder unit. And frankly, what really keeps me busy is I have 5 children. And even though that slide looks very busy, this is actually far busier for me. These are all my relationships with commercial interests. I generally have worked with a number of pharmaceutical companies putting together national education programs for them. And so I've done that for Janssen, Otska, many of them actually on there. It's actually more of an advisory role at this point as opposed to doing too much speaking, as I've been kind of too busy to actually be a speaker. I just kind of put together the education programs for them. So these are the objectives that we'll have today. We're going to go over major depressive disorder, just a general overview in terms of its impact on society and on people. And then also, we're going to talk about factors affecting the risk of suicide, especially with February coming up, which generally is a very low month for many people. And we're going to kind of go over kind of maybe how to identify and assess when somebody's at a higher risk. We'll go over the current algorithm in terms of selection of treatment options. I'm then going to go over a discussion of the most recent meta-analysis in the Lancet, which actually goes over maybe which antidepressants you should consider a little bit more so, because there's so many options. And then lastly, I've just kind of spun in a little bit on the concurrent piece with concurrent addiction and mental health disorder in terms of depression, as well as alcohol use disorder, I think. So often people say, well, you know, psychiatry is the new kid on the block for medical school, and depression's really a new illness of the past century fabricated by psychologists, et cetera, and big pharma. That's totally wrong. Depression has been around pretty much since people have been around. In fact, if you even go to the Bible, there's the Old Testament story of King Saul, which describes the depressive syndrome. When you look at Homer's Iliad, there's the suicide of Ajax described. Hippocrates actually even described melancholia as a medical condition. And it was thought actually to be caused by black bile in Greek. And that's how melancholy actually came to be in terms of the word. One thing I didn't add to this slide in terms of the history of depression is, in fact, the first medical institution located in I believe it was near Pergamon in Turkey. So it was the first medical school really in the many years ago in the time of Hippocrates. In fact, was actually a psychiatric institution where they actually treated patients with hot water baths that were filled with local salts. And interestingly enough, a lot of the local salts are composed of lithium. So they're giving them these lithium baths for patients with like what sounds like catatonia, depression, psychosis, and then kind of having people kind of treated there for a few weeks and then back on their way, feeling much better. So depression is not a new illness of the past century. In fact, it's been around for a very long time. And what's the big deal about depression? Why should we be worried about it? Well, 11% of Canadians will experience a major depressive disorder in their lifetime. That's more than 1 in 10 Canadians. But the interesting thing there is it's not just those people that'll be affected by the depression. As you know, there's a ripple effect on families, friends, work colleagues. And so there's that huge burden for everyone, not just for the patient. In terms of the economic burden, they actually think it costs about $51 billion annually in terms of this mental illness on the Canadian economy. This goes in terms of treatment, but this also actually considers people who are unable to work because of this illness. And up to 50% of patients, unfortunately, with major depressive disorders are not being treated appropriately. There's always lots of problems linked to depression, such as social dysfunction, where they can't actually then make an income due to workplace absenteeism or underperformance while they're there, or could lead to unemployment. So really, depression is a huge deal in Canada. When you actually look at what depression does to your brain, I'm actually surprised psychiatrists treat it, because frankly, it really is a neurological illness as well, you could argue. It actually affects your prefrontal cortex, your anterior cingulate cortex. Pretty much all these major areas of the brain actually have a loss of volume and decreased activity due to depression in functional MRI studies. Interestingly enough, the parts in blue on my slide show actually what treatment does, and treatment actually can normalize the volume in a lot of different parts of the brain if you treat the depression, and that actually has been shown with both psychological and pharmacologic treatments. And once again, just to go over, it's not just in Canada that depression causes a huge burden of illness. Worldwide, and this is by the World Health Organization, in terms of all the different neurological or mental health illnesses, unipolar depression unfortunately causes the most disability, number one, out of any neurologic or psychiatric illness. In fact, actually, some newer data suggests that it might be actually number one, period. In terms of the presence of kind of symptoms associated with kind of more severe and long-term disease burden, they actually find that you do need to treat patients all the way to be asymptomatic. You have to treat the symptoms fully. Because if you have residual symptoms and kind of these subsyndromal symptoms, depression, so they're kind of better, but not completely, their prognosis down the road is a lot worse than treating them to full remission. They'll have longer and more severe episodes. They'll have more symptoms of illness. They'll have longer term psychosocial dysfunction, which is a huge thing because we want to get patients back into work and school and kind of relationships. And then, of course, over the next 10 to 20 years, they actually have a lot more depressive illness burden. In fact, actually, asymptomatic resolution is the strongest predictor of remaining relapse or recurrence free in the future. So it's not even the age of onset or the number of episodes you had before, which we thought was the biggest kind of factor. Treating somebody to full remission is the best thing you can do for their future if you can get them to that point. So actually, this is a discussion question. I know we don't have live mics, but maybe I'll just take a flip through the chat bar. What is involved in the assessment of the risk of suicide, in your opinion? What do you think? So I'll just flip through the chat bar myself here and see what some of your answers. So when you're assessing somebody for a risk of suicide, what are some things that you would assess for? A plan? Yeah. Hopelessness, very good. Of course, them expressing suicidal ideation, their mood, yeah. Protective systems, a history of suicide, yeah. A plan and access, past behavior, previous attempts, yeah. Intent, so yeah, like, so they could have thoughts of hopelessness, but what's their intent in terms of actually wanting to follow through? Family history of suicide, yep, that's also very important. History of addiction is a huge one, yep. Yep, future talks, are they hopeful for the future? That's always a good one to assess. Very good. So really, actually really good answers in there. History of trauma, very important. Spiritual beliefs, actually, we'll go over that for a bit. Okay. ACEs scores, yep, very good. So adverse childhood events. Okay, very good answers, everybody. I'm gonna show you kind of what the CDC actually states is kind of the most relevant risk factors to probably assess. So of course, previous suicide attempt is kind of near the top of the list. If they've tried before, they're gonna be a risk to try again. Any mental illness pretty much puts you at a higher risk. Depression, though, also is one of the highest risk ones. Social isolation, history of criminality, financial issues, if they have a history of impulsivity or aggression, job problems or really any sort of loss, legal issues, any serious illness, especially those with more chronic pain, and a substance use disorder is considered a risk factor as well. If you actually kind of break it down a little bit more, adverse childhood events such as child abuse and neglect, bullying, family history of suicide, relationship problems such as a breakup, violence, or loss of relationship, and also a history of sexual violence. In terms of other modifiable risk factors in the community, any barriers to healthcare is actually a risk factor as well, be it geographic or economic. The cultural and religious beliefs is actually a really interesting one. So if you have a belief that suicide is a noble resolution of a personal problem, and this was actually kind of more in post-war Japan, that actually drove up rates quite a lot. Interestingly enough, too, when they actually look at which religions actually are most protective, because religion is generally seen as a protective factor, as most religions kind of have a an influence on suicidal thoughts by saying, oh, that'll actually be kind of considered, something that this religion doesn't really advocate for most religions. Most religions are actually protective against suicide, except, interestingly enough, Protestantism, which was interesting because in theory, Protestantism also has thoughts on suicide that are negative. However, they actually think, though, that study was possibly influenced by Protestantism generally occurs in societies that have more individualistic belief systems, so such as in kind of North America and Western Europe. Meanwhile, a lot of the places where you'd have more Catholicism, the Muslim religion, even Taoism or Buddhism, occur in places that have kind of more social support and cultural support. And they think that actually probably skewed that data a bit. If there's suicide clusters in the community, that's also a risk factor. So if there's been a lot of suicides, let's say at the school of a student, that actually then raises their risk of suicide, unfortunately, as well. The stigma associated with mental illness or help seeking also unfortunately contributes to suicide. Easy access to lethal means among people at risk, so having firearms available, of course, or medications that have a higher risk of death if you overdose. That would be like tricyclic antidepressants would be a good example of that. And then also unsafe media portrayals of suicide, where if it's glorified in some way, that's something that you always have to be worried about. In fact, the media actually has strict guidelines if they do mention, which they first of all encourage not to mention when celebrities commit suicide. But if they do actually state that there is a suicide, they always have to put a disclaimer kind of at the bottom of the article about how to seek help if you are having those thoughts as well. To flip it though, in terms of those were the risk factors, what are some things that can protect people from suicide? So coping and problem solving skills have been shown to be very protective. Cultural and religious beliefs that discourage suicide. Social connection to friends, family, community support, also very important. The therapeutic alliance with their care providers has been shown to be also a very protective factor. If they feel that they trust you and you actually care for them, that actually has been shown to help for the incidence of suicide in patients. Of course, availability of physical and mental health care. And then, of course, limiting their access to lethal means. So what are the current kind of non-pharmacologic agents recommended for assistance for depression? Exercise has been shown, and this actually has been shown not only to help for depression, but also to help for substance-related outcomes as well, of at least 3 to 4 times a week. It can be aerobic or anaerobic, where you actually then have patients exercising. And this helps actually even as monotherapy, so not any other kind of modalities of treatment for mild to moderate depression. Light therapy has been shown to be very effective for seasonal depression, so people who get very blue in the winter. Now, light therapy is not just sitting under a tanning bed or, maybe, trying to be outside a little bit more. It's actually a light that actually has a medical basis of 10,000 lux, which is a strength of light that actually has to be shining obliquely at a person's face for 30 minutes every morning, and it has to be within a foot of your face. A lot of people put it on the end of the table, and that actually probably won't work. It actually has to be fairly close. We always tell people not to stare directly at it, however, because that can sometimes cause headaches or nausea. Light therapy, interestingly enough, is also shown to be beneficial for even non-seasonal depression. So if you have somebody who cannot exercise and doesn't want to take medications and not interested in psychological interventions, that might be an option then. In terms of naturopathic things you can kind of pick up at the local naturopath store or even pharmacies, St. John's wort, out of all of them, beat out omega-3s and vitamin D even for efficacy. The interesting thing though about St. John's wort though, it's actually highly serotonergic. And so you can sometimes have serotonin syndrome or even risk of mania from it, and if they have a history of bipolar. So it's not as innocuous as everybody kind of thinks, and also interacts with blood thinner medications as well, making them more potent. Now, in terms of psychological treatments, cognitive behavioral therapy has the most ample evidence for acute and maintenance or relapse prevention of treatment for depression. That being said, though, interpersonal therapy, behavioral activation, mindfulness-based CBT, actually psychodynamic should make that list now too, have all been shown to be beneficial for both the acute and maintenance phases of treatment for depression. The actual CBT is just the easiest one to administer generally because it's fairly manualized, easy to learn, easy for them to do, and can be done in the shortest period of time in general. Dialectical behavioral therapy should also be in there as well. In terms of why lifestyle actually helps, in terms of why exercise and a healthy diet can help, they actually think it comes down to our cellular level with mitochondria, and mitochondria are much healthier if you have a healthy diet and exercise. And that then causes this kind of cascade of secondary messengers, including BDNF, which is a brain-derived neuropathic factor, which then actually really helps for your brain cells to flourish. And then to then not only cognitively get better, but also from an emotional context as well. But interestingly enough, you have kind of a worse diet in terms of kind of unhealthy foods, high kind of glycemic kind of load with kind of simple sugars, or very sedentary, you actually cause some oxidative damage to your cells, which then they actually think causes this cascade, which declines your brain function. So really, healthy diet and exercise should be the staple or kind of first rung of treatment, to be honest, and sleep. So in terms of what are the CANMAT, which is our kind of national organization that we use recommendations for antidepressants. Actually, before I go there, I'm just going to take a look here about the chat bar and Q&A maybe, and see if there's any kind of questions so far. So I'm not just doing them all at the end. Jeremy, do you want to cut in it here if there's anything on the Q&A that?
Yeah, I can for sure if you would like.
Yeah.
So I guess kind of going off of your discussion with light therapy.
Yeah.
Excuse me. There's a question: should light therapy be used year-round or only during the winter months?
Great question. If they are spending time outside, then yeah, then use it just over winter months. And if they're actually outside a fair bit over spring and summer, that should probably be appropriate. However, there are some people that, let's say, do shift work over spring and summer, and they actually then won't necessarily get those few hours of sunshine, or they're always kind of working from, let's say, 6 in the morning until 6 or 7 p.m. at night, right, inside somewhere where there's very little light. Then for those patients, yeah, I'd probably still continue the light therapy for them. But if they're getting appropriate, if they, let's say they're really into gardening and they're outside like a fair bit, or they walk their dog like an hour a day, then they could probably stop it in spring or summer.
Perfect. Yeah, and then we can answer one more question, and then if you'd like to continue. So does self-injury or self-harm add to the suicide risk assessment always?
That's a great question. It usually, it does in generality, yes. However, it also has to do to why are they self-injuring themselves. If it's due to emotional release, that's less worrisome than them actually wanting to harm themselves or kill themselves. And so it really comes down to the etiology or mechanism of why they're doing it. That being said, as a whole, self-injury or self-harming behavior does increase your risk of suicide, but especially if it's because they are actually trying to harm themselves, as opposed to self-treatment of emotional pain where they distract themselves, which is often actually the case for people with more cluster B traits. Okay. All right, let's get on to the antidepressants, because I think a lot of questions in the Q&A were about antidepressants, and hopefully they can be answered through this. Pretty much all antidepressants are recommended by CANMAT because they've all been shown to be effective to treat depression. Agomelatine is not available in Canada. That actually is an interesting one that is a melatonin-based agonist combined with a 5-HT2 antagonist, which is a serotonergic feedback loop. It's been working, they use it in Europe a fair bit, but it's not available in Canada. But that's one reason why often we start melatonin as the initial aid for sleep, because not only does it help for sleep, but it actually might even help for depressive symptoms. If you actually look at adjunctive medication, so in terms of, if the first line caused some response but not remission, these are the first line medications that we add on as a strategy. That'd be aripiprazole, quetiapine, and risperidone. Brexpiprazole, which is kind of a newer version of aripiprazole with some modifications, which has more 5-HT2A antagonism or serotonergic activity, actually will likely make that list in the next iteration of our guidelines as well. So how do we currently decide on which antidepressant to use? So there's a lot of different kind of factors there. First of all, we see if they're on other medications, and we have to consider drug-drug interaction. If there's an avoidance of particular side effects, so let's say they're deathly afraid of weight gain or deathly afraid of sexual side effects, that then also affects our choice of antidepressant. And then, of course, the patient preference, kind of has to reign supreme to a degree, because that will actually affect compliance significantly. In terms of things, though, that I look at, though, as a psychiatrist, I also take a look at if they have psychotic features, because if they do, generally we kind of treat them for bipolar or alternatively an antipsychotic and an antidepressant comorbid treatment. For melancholic features, there hasn't really been any antidepressants that have demonstrated superiority. Same with atypical features, although you could argue that they have atypical features, and those are the people that sleep more and eat more. They may have actually bipolar, and then that actually has to lead you down that algorithm a little bit. If they have cognitive dysfunction,